welcome to the School of Speech podcast, presented by SpeechTherapyPD.com. School of Speech is designed specifically for the school-based SLP to come together to discuss current topics, tackle difficult situations, and share our insights. Our goal is to bolster confidence, celebrate our triumphs, and foster a community dedicated to the excellence in the school setting. Welcome, everyone. Thank you for joining us. I am Carolyn Dolby, and I am your SpeechTherapyPD.com podcast host for School of Speech. School of Speech is designed for school-based SLPs to come together to explore trends, share insights, and champion our expertise. Our goal is to bolster confidence, celebrate our triumphs, and foster a community dedicated to the excellence in the school setting. Today's episode is Stuttering Service Delivery in the Schools, Early Childhood Edition. In this episode, we welcome back Nina Reeves, and we are going to be shifting our focus to stuttering support with our early childhood population. Nina is here to discuss effective tactics and techniques for supporting our young children and their families. I'm so excited that Nina is going to be helping us determine appropriate treatment approaches and develop really goals that are attainable. She'll be navigating our discovery of innovative strategies that increase fluency, enhance communication skills, ensuring that our young learners have the tools and the confidence to succeed. Just a little housekeeping. I'm going to do our disclosures. Nina receives royalties in intellectual property and has ownership interest in stuttering therapy resources. She's also receiving an honorarium for her participation with us today. Non-financial, she is on the National Stuttering Association Volunteer Consulting and Advisory Board. For me, I am a salaried for my district as a district support SLP for dysphagia. Public school system. I'm compensated for my graduate work for the University of Houston, and I'm a consultant for school districts across the nation, supporting their program development and staff training. I also receive compensation from Speech Therapy PD for hosting this podcast. Non-financial, I'm a member of Texas Speech and Hearing Feeding and Swallowing Task Force. I volunteer for Feeding Matters, and I'm also a member of ASHA's Special Interest Groups 13 and 16. Without further ado, I really want to tell you more about Nina. She is a board certified specialist in stuttering. She is nationally recognized workshop presenter in the area of stuttering and is the author of clinically based materials. She's a co-owner of Stuttering Therapy Resources. She is a recipient of many awards, including the ASHA Foundation Van Hatten Award, and she's also an ASHA Fellow. She's amazing, and we are so happy to have you. Welcome, Nina. How are you?
I'm doing well. Thanks for having me back.
I know. Well, by popular demand. Last episode, we were talking about school age students, and our audience was amazing and basically begged you to come back, and here you are. And I love that you're going to this focus is going to be on early childhood, and that's where we're going to go. But before I start, if those that are listening, I don't want you to forget her first episode was called Embracing Verbal Diversity, Navigating Stuttering Service Delivery in the Schools. I'm going to say that again for our listeners, again at the end, but I want to make sure that everybody goes and listens to that episode as well. But I say we jump right in, and we're going to be talking all about early childhood. So do you want to start us off about what assessment looks like with children coming into our early childhood special education programs?
Yes, I think that's a good place to start. I want to frame the discussion by sort of leaning towards that verbal diversity idea, because it's, pardon me, it's applicable for early childhood stuttering therapy as well. You know, there's been a lot of changes in therapy for students who stutter, and it continues to evolve in the neurodiversity era. The same holds true for work with young children who stutter. And what I want to start us out with is that the most important understanding is that we want to see our early childhood kiddos and our therapy with a twofold goal. Number one, we want to increase the potential that our early intervention, our appropriate early intervention for stuttering, is to guide children and help them have a larger opportunity to not become chronic, to have stuttering not become chronic, right? We're not going to cure them. We're not going to make their stutter go away, but we are supporting that opportunity for children who have started to stutter to maybe move through the stuttering. Okay. We're also going to create those communication environments that are stutter affirming.
Ooh,
And I know, stay with me. All right.
yeah.
Stutter affirming environments, because we're creating that comfortableness. No matter how I talk at 3 or 4 or 4.5 years old, everybody loves me just the way I am. Okay. Now, we have been talking about this for decades. My co-author and I, Scott Yaris, we talk about this all the time. Somehow we've been talking about how it's okay to stutter for quite a few decades. I'll date myself. But that somehow now we have this language and this groundswell of the neurodiversity era. And now there's language surrounding it, and everybody's starting to actually listen. And so it's really exciting for us to go, yay! No, it's not just okay to stutter a little bit, it's okay to stutter the whole thing. And that can be a huge paradigm shift for caregivers, for teachers, for kids, and especially our profession, who has been rooted in the medical model for quite some time.
Agreed.
Yes, agreed.
Agreed.
And the medical model is fine for certain things that we work on. But as far as kids with a neurodiversity, and stuttering is neurologically based. And we can't get away from that. That is science. It's genetic for some and neurological for all. And so, since we're not going to rewire anyone's brain, we're just now. Having said that, the cool thing about early childhood is that their little pliable brains are not hardwired yet.
Wow.
So that's why we hear in our graduate programs, and when we talk about early childhood, we know that many, if not most kids who start to stutter will move through that. Okay. They throw around the zeitgeist is that it's 70 to 80% of the kids who start to show stuttering will move through it. But that sounds great, right?
Yeah.
70 to 80%, unless you're the parent of the kid with the 20% chance of chronic stuttering.
Okay.
And that doesn't feel so comfortable.
No, it does not.
Right? 20% is a big number. And so our job is to take that population, and we're going to talk about how can we figure out who's who, but we don't have guarantees. How can we take that population and increase the opportunity for them to move through it? Okay. So as we think about that, we can talk about the assessment as finding out what has happened before this child has gotten to us, what is happening now, right? And we're going to look at those key factors that maybe lean towards persistence. And we're going to figure out if this child is more or less likely to continue to stutter. So we're going to talk about that in our assessment.
Okay. So when you said what's happened before, as in, are you asking like how long have they been studying? Is that question? Okay.
Absolutely. Okay. So let's lean right into that. We're going to do a background about this child. We're going to, use some checklists, some forms, some interviews. We'll get the general background information which we do with all our kiddos. We want the medical history and any past therapy, what's been going on with this kiddo, and what have the parents or the, caregivers heard about what's going on, how long has it been going on. So we want this general background and the stutter related background info. Yeah.
Yeah.
And Yeah, and we're going to interview the child, which sounds like, okay, how do you interview a 3 or 4-year-old? But we're going to talk about talking
Mm-hmm.
with the child, and we're going to see how things are going, right? We're going to interview those caregivers about their concerns, if there's any other concomitant or coexisting things going on with the kiddo, and what advice have they been given?
Okay, I see where you're going here because I'm thinking we need to know what they know or what they think they know. So
Yes.
I'm starting to feel we're going to get into some re-education components.
Mhm. And
Okay.
you said it in the intro. Of course, we can support the kiddos, but more importantly, we are going to support the families, any early childhood educators surrounding this child, because this is that time where we're going to create or help to support the comfortable communication environments, not ones that say, now, honey, stop, slow down, start over, take a deep breath, think about what you're going to say, just relax.
Right.
All of that well meaning advice that comes from people who don't really understand what stuttering truly is.
Oh my gosh.
I
And
know.
I know this is just, I know everybody else also that's listening, we're all going, oh, I know that I've done one of those before. I know I've said, oh, wait, just a moment, take a deep breath, give it a minute. I mean, I know all of us listening, but you know what? We're here. And now we're gonna learn because when we know better, we're gonna
We
do
do better.
better.
Yep.
But anyway, I don't want to stop you. I want to go back a little bit to that how important that piece is to understand what the caregiver, the teacher, what are their beliefs? What do they think about it?
Yes.
I haven't heard that before. I
Oh,
need
gosh.
everyone to hear that, how important it is to ask that direct question.
Mhm.
What do you think stuttering is? And what have you been doing? What do you think works?
Yes. Yes. So,
Wow.
how do you, and if you're just listening, Nina's holding up the air quotes.
Yeah.
How do you help your child when they're having some trouble talking? Right. Because that's usually stop, slow down, start over, whatever. So we're gonna find out what's been going on, how long it's been going on, because one of the things we know about stuttering in general, and we talked about this last episode, is that it's variable at its core. And in early childhood, we talk about sort of that cycles as well. It's here, it's gone, it's back, it's higher, it's lower. So it's maybe cyclic and variable.
Oh
And
boy.
that's what keeps caregivers from getting the kid in the door, is because the kid started to stutter and then they didn't hear it for a while and it went, quote unquote, went away, and then it comes back and then but what happens is, this is sort of, for many children, not all, some start to stutter and they just stutter, and there's no cycles, it's just variable, and the parents are like, oh my gosh. But we know that that sort of prolongs the referral sometimes, because another thing is that, well-meaning pediatricians say, don't worry, they'll grow out of it.
Yes. I feel like that is their catchphrase for almost everything. I'm coming from the feeding world. And when a parent says, well, I went to the pediatrician, they said, oh, they're a picky eater. Oh, they'll grow out of it.
Yeah,
Ah,
I know. And so that's been a big part of the stuttering world's trying to educate pediatricians, which is great. However, that again, we have to be cognizant that the parent or the caregiver has gotten conflicting advice
sure.
prior to what they've gotten on the internet, which is you
Yeah.
know very dicey, and they've gotten the pediatrician, or they got Aunt Betty, or, oh, don't
Mhm.
worry, your cousin grew out of his, whatever. And
Right.
so, yeah, it's all, everybody has an idea, except no one really knows what stuttering is. And so this caregiver is like, oh my gosh, what, am I doing the right thing? Did I wait too long? And then the guilt and the worry starts to con- compound, right?
Mhm.
So we want to gather all of that. We want to know what's going on with the caregivers as well as with the child, because how the caregiver believes is what they're going to then behave. Okay. Beliefs drive behaviors.
Mhm.
And
Yes.
so, you know, they're talking faster than they can think. Oh, let's slow down, honey.
Oh,
They're
I get
thinking
it.
faster than they can talk. Just think about what you're going to say and then say it. Okay. Not realizing that's just a trick in the moment to get a different neurological pathway to happen. And it didn't make the child fluent. It just switched the neurology. And there may be fluency in that track. I don't know. So it's very complicated, but also extremely scientific. This is not some aberration that sort of appears. It's very science, from neurologically based to the factors that impact it. All right. So speaking of factors that impact it, let's talk
Yeah,
about
let's get
the
into that.
assessment,
Lay
right?
those out on me. Yeah.
So as always, I'm going to refer every listener to the ICF framework. Okay.
Mhm.
The International Classification of Functioning, Disability, and Health from the World Health Organization. And they can find so much about that on our website. In all of our writings, Scott Yaris was one of the co-authors of the ICF as it relates to stuttering. Okay. So it's there for the understanding that we are going to look at function, reactions, environment, and impact. Okay.
Function, reaction,
Environment and
environment,
impact.
and
Yeah.
impact. Okay.
And that's how we're going to think about the referral. It's how we're going to think about the assessment. It's how we're going to think about writing goals and doing therapy, even with early childhood, solidly in the school age. But even with early childhood, I want us to think about that bigger picture, because everyone for hundreds of years has only been focused on the moment of stuttering.
True.
And I'm going to say this, the moment of stuttering that we can see, which is not very many of them.
Okay, if those of you that are just listening, I kind of have an eye gasp. This is an aha, because this is a tip of an iceberg that you just hit
Yes.
when you just said that we judge stuttering from what we can see, and you're telling us that we are not seeing even.
We're seeing some.
That's powerful.
Some. That is why you're not going to hear me say, let's count some stutters.
Okay.
Yeah.
Right. Like, how many times are they stuttering?
Right. How many times are they stuttering? Well, it's only the amount of times you saw them.
Right.
Yeah. I bet some of our listeners remember Sheehan's iceberg, Joseph Sheehan's iceberg, where the tip of the iceberg is what you can see above the surface.
Yep.
So it's, as Scott and I play around with these words, it's the listener's experience of the speaker's stuttering.
Wow.
But it's not the speaker's experience of their stuttering. The internal, I'm stuck, we may never see. Okay. We'll see it.
Yeah,
but
no, I know what you
we
mean.
won't
No,
see it. Yeah.
yeah.
The internal stuckness in that vocal tract and in that whole system of, how speech happens. There's a moment of stuckness, and then there's like, okay, trying to get it out. Yeah. So we may see the repetition, the prolongation, or the block. We may see it, or it may be subclinical. Like you can't even, it's there, but you can't see it. So that's why counting stutter is a total waste of time. But I digress. We'll talk about it.
Okay.
But it is.
We're gonna come back. We're not going to be counting stuttering. Okay.
No, and I will talk about, and you're going to remind me to talk about the fact that, yes, there are many people that expect in the public schools that we have a count.
Yes.
So let me just get that off the table right now.
Let's talk about that.
Let's talk about that. I have counted my students stuttering over the past 20 years, once every 3 years, because I'm forced to.
Right.
That's it. I never count a stutter in between. I don't care how many times I see their stuttering, their surface stuttering, because that doesn't translate into their experience of stuttering.
Wow.
Yeah. And so, but we do have to be observers. I am not going to take that away, because 3-year-olds usually can't say, I'm feeling stuck in my vocal cords. And you didn't see that, but I was stuck like for 3 seconds. They're not going to be able to tell us that. So we will need that observation. I'm not taking it away, but I'm taking away, if I could be so bold, the reliance on that for, number one, eligibility. It should never be determination of eligibility, how many times they stuttered or didn't, because it's not real. And number two, any kind of progress in therapy cannot be measured by how many times you saw that child stutter.
Okay.
I know it's big.
This is big. This is a mind shift. So I'm going to as I'm soaking in, this is my question.
Mm-hmm.
Because I know that a lot of times we will write as in the eligibility that they are mild stutter. They are severe. They're severe and what's the word? So you're saying that that is our experience, and therefore it's not a true, it's not true representation. Therefore, that eligibility should not be that they're a mild stutterer, because that is our perception of what it is.
Mm-hmm. Yep.
Okay. I hope all the listeners and watchers, you just got
Stay
that.
with us. Stay with us.
Okay.
This is big. This is a shift.
Is.
It's a culture shift.
I like that culture shift.
It's a culture shift, which is slow, and you have to be patient and persistent, right?
Yeah.
And you have to be understanding and give grace, but you're also not going to wait forever. It's like, okay, come on, people, let's move. Because here's the deal. Neurologically based, verbal diversity, which means it's a difference, not a defect.
I like it. Yep.
That's singer, Judy Singer, right? 1999, I think. And everybody before her, that was just, she coined it in writing. I think she has already said, I know it from all my discussions with neurodiverse people. Start listening to neurodiverse people, as we know, with the autistic community and all of that. So that's what that groundswell has become, is that it's now looking at not just what you see on the surface, but what the person is experiencing. So let's just take this for a moment. I know we're moving a little different, but we have to stay here. If I'm going to talk about what we're going to assess and how we're going to look at progress in therapy and write goals, we can't move from this spot till we think about the fact that the speaker's experience of stuttering doesn't always translate to what we see. So if we're relying on what we see to determine eligibility or determine progress in therapy, we're looking at the wrong thing.
Okay.
We just are.
Okay.
All right. So we're going to shift away from that and use that ICF model. That's why I so talk about the ICF model, which is in our scope of practice, by the way.
Sure is.
Because it tells us this, it's the bigger picture. It's not just the impairment of body structure or function. It's the reactions, the environment, and the impact that is, and they all feed on each other. Okay. All right. So when we get those observations, it's still very important to take a look at what we see. We just can't stop there. Yeah. So if you're forced to count some stutters once every 3 years for the triennial and move on.
Got it.
Right.
Okay.
There may be something someday, maybe, about assessing without counting stutters. Maybe, wink, wink. But right now, not yet. So let's talk about the fact that if we do it, we're just going to say, this is a snapshot of what I could see on these 2 days with this, in these 2 speaking situations or 3 speaking. This is a great snapshot of what I observed.
I think that's important. What you're saying is, when we're writing that up, that we need to say, we need to be transparent that what we're saying is, this is what the clinician observed this, not saying that this is the end all, because we're just saying during this time, this is what my impression, what I experienced.
Yes.
Yeah.
What I observed about your child's surface stuttering behaviors. Okay.
Did you hear that, everyone? This is what I observed of your child's surface stutters.
Yep. The
I
ones
had
we
to
could see.
repeat that, Nina. That's powerful. Thank you.
Yeah. Well, I love that because it's the idea of saying, okay, this is why you're not going to hear me talk about. Now we're going to try to decrease those moments of stuttering.
Okay.
Right? Because that's going to be chasing a grease pig because, stuttering's variable and you're not seeing all of it anyway. What if the child, let's just say a 5-year-old that's not in kindergarten yet and it is in your early childhood, has already figured out that people don't want to see him stutter or he's uncomfortable with his stutter. So he just changes the word or he doesn't say as many words. So he has apparent fluency, but he was stuttering on the inside.
Wow.
And that is not something we want to rejoice about.
No.
Oh, yay, you hardly stuttered at all. Well, when we praise fluency, we are looking at the wrong thing. How about we shift to communication? Let's praise communication. Stuttered, non-stuttered, high, low, fast, slow, smooth, bumpy. Let's just praise communication and look for, is this child communicating effectively?
Okay.
Getting their point across in a variety of settings, which is most state standards,
Yes.
the child will communicate effectively in a variety of settings. It doesn't say the child will communicate fluently.
No,
there's some reading fluency stuff that everybody gets all confused about, but this does not say fluency anywhere. And if it does, somebody better contact their state.
Yeah.
Right? Because nobody's fluent. Everybody's disfluent and some people stutter.
Okay. You just said that everyone is disfluent, but only some stutter.
Right. Yeah. We all jumble our words. So when everybody goes, oh, I stutter too, it's like, no, you don't. Do you have an out of control physical motor manifestation of a neurologically based condition? No, you don't. That was a language thing or just a moment of word finding or you revised. Yes, we are disfluent, but there is research, and this is Scott's research and his colleagues, it's stuckness. There has to be some stuckness. That's the rubber meets the road, right? They're trying to move forward with their speech and they can't. They know what they want to say. They can't get it out of their mouths. And how tight, a little tight, a lot tight. And I'm just going to say this is going to be heresy for some people, but I took the severity ratings off of whenever I was working with a district, the severity ratings had to go.
Okay. That's kind of what I couldn't remember that. That's what I was kind of getting to earlier. And I couldn't remember what it was called, the severity rating. Yeah.
So it's fine. They're on the assessments. It's fine. But when you say to a parent or, the grandparents that are taking care of the child, whoever it is, the caregiver, and you say this child has a severe stutter. I mean, why? First of all, the child is not severe all the time because stuttering is variable.
Yep.
It was that snapshot in that moment. They had a significant amount of stutters or that was pretty tight. So let's use descriptive words. All right. We can talk about, there was a significant impact. Okay. But not that there's a significant stutter, because what if there's a child who stutters big, but doesn't care and talks up a storm?
Oh,
they have severe stuttering on the outside, but inside they're not as impacted and they're just communicating. So it's not a one-to-one correlation. How much stuttering you see doesn't really define then how much impact the child has. It's not a straight line. There can be a mild stutterer that is totally freaked out and doesn't want to open their mouth.
Which goes to when you were talking about the example, when you talked about the kindergartner that figured out that certain words, so he shortened his MLUs, possibly, or just switch the word, or I'm telling you, this is something to be thinking about. Like, how did that child get fluent in that moment?
They could have just had some fluent speech. Kids who stutter have fluent speech. They have flow. They don't get stuck. They have regular disfluencies, like we all have. And then they have some stutters, and then they have some fluency. So it's a mix. So they could have just had some regular fluency. They could have been avoiding. And of course, they could have been trying to manage it or control it with the old way of like turtle talk and all of that. We're getting rid of that. Let's have a funeral for the turtle.
Okay, everybody. Goodbye, R.I.P. Goodbye, turtle.
R.I.P. Oh, we should do that little turtle upside down.
Yeah, totally.
Baby. Sorry, we're going to get to that. So anyway, this is all important because see how all this weaves together, how the therapy, we're talking about assessment. And right away, we're understanding that the therapy is not going to look like what we thought it was going to look like.
Right.
Now, we're going to do these background things. We're wheel back to that. Okay, we got the background, and then we're going to do some observations, which I said are fine and great as long as we don't put too much, emphasis on them. The caregiver, I want to see the caregiver and child interact. If, caregiver can send me, in the schools, we can't always have that. So send me a video of just playing. Don't interrogate the child, just play. And let's just watch. Okay. The child's speech in various situations. Okay. Some videos from home, some things we do in the therapy room, different, speaking situations where, we're just chatting. And then we try to have them do the remote event. Like, tell me about the time you went to the amusement park. So see how language load, we have to bring our language knowledge right to this. Okay. Because language load impacts the system of a little kid. Yeah. And may impact how much stuttering you see or not.
Okay.
But we have to be cognizant. We're just not going to have the kid do one thing and go, here's your stuttering. It's going to have to be a couple of different speaking situations.
Okay. I see what you're saying.
Yeah.
Right. Just having them tell me about this picture.
Right. And that's great. But then they describe or they point and they say, words. And then we want to say, oh, tell me about a time that you went to this amusement park or a amusement park like this. And then the language loads gets going. And then there's a different neurology happening. And we just want to bring all that in.
Okay.
So we're going to see that. And then we're going to do some baselines because kids who stutter don't always come with just stuttering. They may have some language, some articulation, some phonology. We want to make sure their hearing is fine. I love to have a little temperament scale if I can, but I know a lot of school districts don't have those, so I'm not even going to talk about it. But I do ask about it on these checklists. When we write our checklists and our things for parents to fill out, we do kind of write, how does your child deal with, changes in different situations and things like that. Just want to know. And then when we do the protocols, okay, the protocols and the interviews, we're going to look back at that ICF and we're going to realize we're going to do some age appropriate interviews with the child, with others, and then the assessments of the speech fluency, right? And the stuttering. We have things like I think the SSI goes down that far. I don't think the TOX does not go down to the preschool age, the test of childhood stuttering. So we do that. I haven't done, I'm not going to say that. I do a transcription, like a language sample.
Okay.
I video every single stuttering assessment ever. There's no reason not to video these things because then you can see, is there tightness elsewhere? Are there secondary features? Did that child switch that word just now? What am I looking at? Okay, so we're still observing, still important, right? But I'm videotaping it so I don't have to try to do something on a piece of paper. I'm just listening to the child, letting the video roll, and then I'm going to go back and write a narrative about what I saw.
That is amazing.
Yeah.
Think
Two
about
birds, one
I'm
stone.
just thinking of me when I was a campus speech path doing right. And they're watching you. What did you, rather than, okay.
They're watching you do pluses and minuses on a piece of paper. I even have
Exactly.
clinicians that have told me they do the clicker underneath. This is a fluent. I'm like, no, 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 let's stop. Sit back and wonder, what is that child thinking while you're doing it? Some of
Mhm.
them don't notice. Many of them do.
Yeah,
They know what a plus is and what a minus is, something good and something not good.
absolutely.
We're not going to do that. We're just going to let the video roll and we'll do that assessment. But we also want to do, okay, so that's the, function,
Yeah.
right?
Okay.
Observable seeming function. Then we're going to do the reactions. We want to know from others and from the child how they feel about their communication. Okay. Do you like to talk? Who do you like to talk to? All of those types of things. And
Mhm.
then finding out if the caregiver has noticed any change in the child's, you know, are they withdrawing? Do you feel like they're giving up? Or do they seem frustrated? Okay. I've had parents tell me, oh, mommy, you say it. 3.5 years old, the kid's going, mommy, you say it after they get stuck.
Sure.
Not just because they're shy. I'm not trying to change a shy personality. They get to be shy. But if
Right.
it's about the stutter, we can see some of those things. Yeah. And we can ask too, because not all preschoolers are 3. Some preschoolers are 5.
Yeah, they are.
And you can have different conversations at different levels. Yeah.
Mm-hmm.
We're also going to find out what the environment knows. We already decided, in those checklists and things, but we do have to take on the idea of making sure we know what the culture. We want to be culturally perceptive and understand to make sure what does that culture view stuttering as?
Mm-hmm.
How is it viewed in the family? Sure. How is it viewed in the classroom? Sure. And is there a cultural background to this? Okay. And
Wow.
then we want to find out about the impact. So it's the function, reactions, the environment, and impact. That's where the parents might say she's frustrated, she gives up, she holds her mouth over her hand over her mouth when she gets stuck or when her speech is bumpy, whatever they say.
Yeah.
And then we're going to also watch for those things while the child talks as well and what they're saying to us.
Mhm.
Yeah, I've had little kids say, I get bumpy and I don't like it.
Wow. That's your
That's
impact right there.
diagnostic.
Right
That's
there. Yeah.
right there. That's reaction. And then probably impact follows.
Right.
And that might be internal or it might be from the environment saying, now, honey, because everybody's trying to fix it. Well
Mm.
meaning. Boy, are they normal. I don't tell parents like, wow, that was, not good. It's more like, hey, of course, you're
Mhm.
watching your child struggle with something and you want to help it. You want to fix it. All right. So we're going to gather all this information. We want to know how willing is this child to talk. If they're bumping along and talking all over the place, it's like great news
Mhm.
because we're no longer focusing only on the bumping along. We're focusing on chatting up a storm. I'm getting my point across. I want to talk to everybody, but we have to then look at that persistent for stuttering analysis. And I told you I was going to get to that. So let me make sure I do.
Okay.
There's been a huge amount of research done in decades and decades. There have been some really good reviews of the research of late that have kind of told us, okay, that no longer really stands. Somebody did that nice study with 3 kids and that
Mhm.
no longer stands. That's good. We need to know that. But the things that we want to think about, children who persist compared to children who eventually move through this
Mhm.
are more likely to be male.
Okay.
It
Yeah.
just is. We have more males who have all kinds of communication issues. We have more males on our caseload. We just do.
Yeah, we do.
They catch up later, but they're
Mhm.
more likely to be male. They may begin stuttering at a later age. That's a factor towards persistence. Or they have known family histories of stuttering,
Okay.
either persistent or recovered. I want to know the family history. Talking to a parent this morning. Oh my gosh, but my husband had some speech impediment. This is what she said.
Mhm.
And he went, it went away. So we're hoping that for my son, who's 12, by the way.
Oh boy.
All right, that's okay. But that's what they know. Then I
Mhm.
found out her husband never stuttered. It was articulation. Everybody lumps speech together. He didn't grow through stuttering. He went to speech therapy and got some articulation. He wasn't understandable. It was, and so that child had been going, I want to be like dad. I want this to go away like dad's did. It never happened.
No.
So we have to be we have to grab that information and pull it out. Is there a known family history of actual stuttering?
Okay, right.
Not an urban legend, but actual stuttering. And then we see kids with a higher rate of stuttered dysfluencies, like there's more stuttered than non-stuttered.
Oh, okay.
Because we don't just measure stuttered dysfluencies. We look at non-stuttered, the things that we do, the revision, is the child using it because they're 3 and they're just learning language? Or are they doing it to try to get a stutter started? We have to be watchful of that. That's why the video helps.
Yes.
And then, we want to look at those other factors like speech, sound accuracy, expressive language, receptive language. We want to see if there's any other things going on because that affects communication.
Sure.
And since we're looking at communication, we have to look at all of it.
Absolutely.
And so those are the factors that have come out that have data that let us, there used to be like 10 more. And now we're down to those that really sort of hold tight. Now, I can have all of those going on and the kid can move through their stutter in 6 weeks. I can have none of them going on and the child may stutter persistently. Okay. So we don't have a guarantee. These are what we do clinically with our evidence-based practice that says, okay, this child has some of these factors towards persistence. And so my radar is up.
Okay.
For eligibility for putting them into therapy. Yeah. They don't have to have a lot of them, to have therapy. I'm just saying we want to know these things.
Okay.
Right. And so that's the assessment aspect.
I think my takeaway, everything's been amazing. I think the one takeaway is that video component you're saying. And again, it's a comprehensive assessment is what you're saying. It's not just counting stutters.
Yeah.
It's the whole language and looking at it. I'm just trying to get this for our listeners too. It's the whole language of communication.
Yep. It's the whole enchilada.
The whole enchilada.
We want this child's experience of communication, all of it. So that because those factors inform our decisions and then inform our therapy planning, which leads us right into goals.
Yeah, that is a great segue because I know that's what
segue right in there.
Okay, so now we've done our assessment. We've got the eligibility. Now, how do we even look at goals now? Because most of us are like, oh, I did the goals. If they're going to decrease their
fluency.
Yeah, exactly.
Yeah. Now here's where this is where we're still sort of, we have to think about this, right? So we don't want to be ableist and say this child needs to get fluent. Okay. Right. But in early childhood, and in early childhood, we want to also think about the fact that we have this little window of opportunity to try to move the needle, maybe away from persistence. Okay. So it's not a cure, but we're moving the needle away from persistence and back towards, non-stuttered speech.
Okay.
Notice I didn't say fluent speech.
No, you didn't. Non-stutter.
All right. Non-stuttered speech. So I have a blog that I'm going to be writing in the next couple of months. Is it ableist to even talk about fluency? And, I'm sure everybody has a different view of it, but I am thinking in this little part, it's okay to say we're going to try to help the child have some more flow. We're just not going to have them talk different. Like and we'll get to that in the goals and then the therapy part. How are we going to expand this opportunity for them to have easier communication? Okay. Well, we're going to look at the communication environment that this child is under. And that's when we get into the parents, the teachers, the caregivers, around the child and say, let's set up a communication environment that decreases the stressors
Okay. Yeah.
on the child's system and increases their opportunity for them to just take their time for talking, not slow down, not take a deep breath, right? They just get to talk without that stressor. Like, I have to talk fast or my brother's going to interrupt me. I have to say it quick. The kids aren't even cognizant that they're thinking this, but they're like blah, 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 right? And they're 3, they're 4, they just want to talk.
Right.
So let's give them that space. Let's do the environmental things, because environment doesn't cause stuttering, but it can exacerbate it.
Right. Because you were saying that the environment, if you said we want to decrease the stressors.
Yeah, the stressors.
The stressors. So yeah, the environment's not causing the stutter. It's the stressors within that environment
Can
that
exacerbate it. They don't cause it, but they can, feeling like you have to talk fast, all of that. That's why people say slow down. But it's not about slowing down. You don't have to do artificial speech.
Did you all hear that? You do not have to do artificial speech.
I want to ask, just in their heads right now, as you're, driving or listening, I want you to think, how many times have you ever had an early childhood kid turtle talk outside of a therapy session? Do they ever go, oh, I love the turtle talk. Hi, Miss Nina. I'll tell you about the baseball game. Never. They'll do it when you cue it and when you imitate it, and they'll do it for you so they can get their turn at Chutes and Ladders.
Right.
But they're not, it doesn't carry over because they're just developing speech and language. They just want to talk.
Yeah.
Okay. So the system is fragile. The neurology, the system of this kiddo has some glitches right now. So we want to create a space where we can just decrease some of those stressors. It's like Starkweather and Givens, the demands and capacities model, for those of us in, back in our graduate school, like, oh, I remember that. So it's this idea, we're just going to turn down the fire hose of communication. You talk, I talk, I interrupt you, I'm talking fast, and I listen. Oof. Obviously, I'm a fast talker. Okay. When I'm with my little kiddos, I try to tone it down a bit, but I used to, when I was a young clinician, talk like this, as if the 3-year-old was going to follow that. It's like, sometimes I look at old videos of me and go, really?
You're like, what was I
When
doing?
you know better, you do better.
Yep. I love
So
that.
now I just try to tone it down. Just, speak in a way that allows some pausing. A little silence.
I love it.
Happen, right?
Yeah.
And just take it down a notch. So, and creating that space where all kinds of speech are accepted. High, low, fast, slow, smooth, bumpy, tight, stuck, stuttered, non-stuttered. Nobody's going to stop a child, okay, and say, now try that one easy. Right? Because isn't that a little like, oh, I don't know, ableist? No, but we are going to try to enhance the fluency enhancing environment, right? We're going to try to bring together a way that this child can feel, a little more at ease with the communication. Okay. So that's the easy communication environment, healthy communication attitudes. And I alluded to that with all kinds of, we have all voices. We have like verbal diversity. We have all these voices, the way our speech works, and all of them are okay. We're not going to single one out and say, wait, that everybody's okay, except when you do that. Yeah. Right. And then we want to make sure we're writing goals that talk about expanding their participation, creating, a space in those communication environments for any child that sort of started to pull back. We want to increase their participation in communication, access whatever their needs are by talking. Okay. because we're all, in essence, we're trying to decrease that adverse impact of stuttering on their quality of life. Now, that's a lot to swallow.
It
Okay.
is.
You know, we're going to write those well-formed treatment goals. So we're going to talk about what the child will do, in what context. We all know how to do this. How much support are they going to get? What's the criterion level? How are we going to be measuring it? And what is, you know, in what frequency or period, 36 instructional weeks, blah, 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 blah. So we're going to take all that we know about writing a well-formed treatment goal. We're just going to switch away from the child will demonstrate, less than 5% stutters in the therapy room with clinician cues. Okay, that is having them speak in a different way, or looking for progress by number of stutters that you can see.
Right.
Yeah.
Yeah, which you've already, I mean, I'm a believer. I know everybody, we're believers now.
Yes.
That
Yeah. It's like, but then everybody gets nervous. Like, what am I going to do? How am I going to write it?
So now, okay. Now we all are on the edge of our seats.
Yeah.
Like, okay, we've got to, we need now, tell us, what are we going to?
So we're going to grab that ICF.
Okay.
And we're going to find out what's going on with function, reactions, environment, and impact. And we're going to find the strengths in those areas to help. We already know how to do this in language and in everything else. We're strength-based.
Yes.
And then we try to narrow the gap of the challenges. Okay. Yes. And so that's where we're working. I wish we could write goals for the environment. The parents will, the teacher will, but so we're going to write the goals that will talk about what the child will be doing as we are engaging with the caregivers and educating the caregivers and helping them create communication environments. Yeah. All right. And everybody's going to write that a little differently. I wish I could give you a goal bank, but we're never going to do that, because that takes your brain away and it takes your knowledge of that child and dumps it on a page. Because you can write a great goal, but if you have no idea how to do it, it doesn't matter. Right. That you have a great, well-formed goal that Nina Reeves said you should write.
Yeah.
But now that's on my paperwork, but I don't know how to do that therapy. So now we're going to go into therapy.
Okay.
All right. So now I'm just going to tell you, if you haven't been on our website, I'm not here to sell you books, or anything else, but if you haven't been on our website, you're missing a ton of free handouts, videos, blogs on this. I think Scott has written, I've written a couple on early childhood, but Scott has probably written 5 about, exactly what we're talking about right now.
Can we give the listeners and watchers your website?
Oh, yeah. Stutteringtherapyresources.com. There's our logo behind me. And I'm going to tell you, we named the company what it is. It's Stuttering Therapy Resources. And so when we went out to write the early childhood book, the comprehensive guide for assessment and blah, 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 it was supposed to be half the size of our school age guide, and it ended up being bigger.
Wow.
Because once we started writing, we started realizing this is when the parents and the caregivers are they know nothing, or they think they know, but they don't know. And we started writing all of these, paragraphs about, if the parent asks this, these are the concepts you need to consider. This is some things that we say. It's not a script, but why we say it. Here's the reason. So we give you the principle behind how this all comes out. And then I really want people to understand, even in the public schools, I had the preschool stuttering intervention groups in my district, and I co-taught with another SLP. I had the parents in another room while the kids were with the other SLP. We team taught, and it was just constant. This is what we're doing this week. This is what we're focusing on. You're going to have decreased verbal competition at your house. In other words, let's decrease the interruptions and the rapid fire questioning. Okay. We're still going to talk to our kids. We're going to ask questions. Don't be worried about that, but we're not going to rapid fire. What did you do today? How did you do it? What did you eat for lunch? It's like the interrogation in the carpool line. We're just going to back off for a little while. We're going to be interested in our child. We're not going to be afraid to talk or ask them questions. We're just going to take down the stressors.
Okay.
And that sets up that easier communication environment and gives the parents something to do instead of stop, slow down, start over, take a deep breath. Oh my gosh, let's get this done by kindergarten, which is how. And we validate that, and we don't tell them they're doing something wrong. We just say, let's just talk about longer term. We want them to feel okay no matter how they're talking. Because if your child continues to stutter, and I do say those words out loud, because I don't give guarantees. I don't say, we're going to do this therapy for this long and they're going to be fine. Okay. If your child continues to stutter, we want them to have that feeling that they are okay just the way they are. We plant that seed right now. And we do these other things to try to move the needle.
Okay.
Yeah. So in therapy, and I know we're getting to the time, I can feel it, but in therapy, it's just most important to, increase that likelihood of that return to non-stutter disfluencies. But we want to have appropriate expectations for you and for the caregivers. Okay. You are not expected to cure the stutter. Okay. It's what everybody wants from you. But in early childhood, we get a chance to move the needle. Okay. Maybe this child will move through this, and we're trying to increase that likelihood. Yeah. I'm never going to know if what I did or what the parent did was the reason this child is now on monitor and is now dismissed. Okay. I'm never going to know, because it's unethical for me to go, hey, kid, you don't get therapy, so I can prove my therapy works.
Right.
It's not going to happen. So just helping them understand that variability is normal. Because you don't want the parent to constantly, the caregiver, to the teacher to constantly, he was stuttering more today. Should we practice? Practice what? Right? That hit. The child may stutter while they're in a hammock in the Caribbean on the most relaxed beach you can ever see, and they could have their biggest stuttering ever. And it's not going to be anybody's fault. It's the nature of the condition. So having them understand that sort of relieves them of, he's stuttering more. I didn't give him a nap. Should I have given him a nap? Parents will drive themselves crazy.
Sure.
Okay. So we have to have that involvement. When I was in the public schools and the money started to dry up for us to team teach, it became apparent that I had to send home handouts. That's what ended up in this book. It was the handouts about what you're going to work on this week. You as mom, dad, grandma, whatever, auntie, foster parent, doesn't matter.
Yeah.
You're going to work on this one thing. Okay. And we might work on it for a couple of weeks. So, and there'll be some feedback, and I'll ask you about it. I'll send you an email. You write it. They have a stutter notebook, even that early, so that we can chat back and forth in an easy, sort of effective and efficient way, because none of us have time to pick up the phone every day.
Right.
So we have to have that essential involvement. And don't forget those early childhood teachers, because they're going to want to, just wait, honey,
Yeah.
They're so well-meaning. We're going to think about cultural competence. We're going to make sure we're evidence-based. We're going to decrease that adverse impact. And we're going to do that through that stutter affirming mindset we talked about in the verbal diversity. Okay. We switch the mindset, which then switches our model. Our model doesn't become, oh, let's make that smooth. We don't send the message that you did something wrong when you stuttered. Okay. Oh, bumpy happens. Yep. High, low, fast, slow. All kinds of voices.
Okay.
That happens sometimes. Naturalize it, normalize it. That child's neurology right now, maybe not forever, but that child's neurology right now has some stutters in it. And instead of thinking it as some aberrant thing that we've got to fix, which is the medical model. It's a pathology. It's not. It's a neurodiversity. It's a verbal diversity. When we get that stutter affirming verbal diversity mindset, then the model changes. Then we can talk more about functional communication instead of fluent communication.
Okay. So I'm hearing, like, rather than saying the child's going to have fluent speech, the goal would be the child's going to have functional communication.
Easier communication.
Easier communication.
The child is going to communicate effectively in a variety of settings.
Boom.
Boom. That's it. You don't have to have, and with less stutters.
No, right.
But we do.
I know. And so everyone that is watching or listening, listen to that, hear that the goal is going to be that the child is going to increase their communication efficiency,
their effectiveness, efficiency,
effective
joy, spontaneity, non-worry, don't freak out, everybody's fine.
And so that's what's going to drive the change in your therapy, is what you're saying, is because now your therapy is going to be working on neuro affirming stutter environment. And then what are we doing? What are we doing?
Well, we're creating that environment. We're helping the people around the child.
Yeah.
Okay. That's huge.
Okay. And I think
now if the child can't,
yeah.
And so I want to say, no, I'm sorry. Yes, this is all that sort of less direct therapy. Okay. Now, if you've got a 4-year-old who can't get 3 words out of their mouth, okay, we're not just going to go, oh, I'll just talk in an easier way. Good luck. No, we're going to have to, we're going to have to talk about talking, and we can talk about getting stuck. And all of this is, in our books and on our blogs and everything. The idea is we talk about talking. It's a Dean Williams thing, right? Quintessential researcher, clinician, love him. And it was all this idea that it's not going to be like, oh, there's your stutter. Oh, there's your stutter. It's more like, how did that one feel? Did that one feel stuck? Okay. Yeah. So, and can we ease it? Yes. Or, yep, stuck happens sometimes, but we're not going to make a child look at that and say, oh, I've got to do something with that. Okay. Now, if they feel, and let me just say, this is the toughest part for everybody to understand. This is the parent I was talking to this morning. The more a child tries not to stutter, the harder the stuttering is going to be.
The more a child tries to not stutter, the harder the stuttering will be.
Yeah, that's the reactions component. That's the, oh my gosh, and then let me push, and then let me change, and then let me not talk. Then everything becomes a reaction to the stuckness that is a negative reaction. Instead of here comes the stutter, there goes the stutter. Like so much of the struggle behavior that we see, those secondaries are secondary because it's struggle. The kid isn't going, let me, blink my eye.
Right.
And it'll come out, but they're pushing to get it out. That's the reaction to feeling stuck. Of course. If we felt stuck in our speech, we wouldn't be like, hey, let me just ease that up. We'd be going like, oh, it's a normal reaction, yet continues to create more trouble. So there's nothing to suggest like a control or a masking or speaking in artificial ways. We talk about easy. We talk about not as tight. We can do all of that, even with younger kids at their age appropriate, vocabulary. We just talk about talking. And if all kinds of talking are okay, then the therapy environment and the home environment and the classroom environment becomes less focused on trying to quelch it. Because what you're trying to do is tell a child in a neurological moment to not do that. That's like saying, Scott uses the example, would you write a 20% less autistic goal?
Oh my gosh. I know you're not, that was another mind-blowing moment.
Right.
We would never write a goal that the child will now be 20% less autistic.
Yeah. Now, in the past, it's kind of what we were doing, but, because we were teaching them to mask and teaching them to fit in. And, there is a point at which many, even the autistic community will say, hey, I need to get through this, interview. Like, I could use some
Right.
support in the communication. Yeah. But I'm not going to turn myself into a non-autistic person.
No.
I'm still going to show up as me.
Right.
Otherwise, I'm never going to feel okay with myself.
So so the therapy is what you're saying is the therapy needs to, the goal needs to be on that total communication.
Yes.
The ease of communication, the effectiveness of their communication.
Yes.
And then therapy is providing them the environment with less stressor.
Yeah.
But then talking about helping them.
If they need it, if they need more direct therapy.
Right. Or,
maybe they won't even need that. Who knows?
Okay.
Yeah. But I'm not saying you get a kid and in the referral stage, they can't get 2 words out of their mouth and all you're going to do is help the parents create an environment. No, you're going to have to be like, okay, this is a child who is struggling already.
And then we need to figure out where that struggle is and then give them those tools of what they can do.
Well, just give them the idea that it can feel easier. I don't know that a 4-year-old is going to carry this over, but I also want them to know that, first of all, it's okay that happened.
Good. Okay.
Number one, always. It's not just okay to stutter the little ones. It's okay to stutter the big chunky ones too. Right. And so the more a child tries to control it, see, we have to be careful with the strategies or the skills.
Yeah.
We have to be careful with that, because if we're introducing a strategy so that the child will stutter less, we're ableist right there.
Right.
Like we're already backwards.
See where I was going? I was already going wrong. Get me back here.
That's okay. This takes a while.
Right.
You know what? I was trained in medical model, not as much as other people were, because I had a Van Riperen trained guy who stutters teaching 2 courses in stuttering back in the day. I know people don't get that anymore, right? So I was less involved in the ableism, but Van Riper was, a little bit of the, manage and handle. Yeah. And now it's more like, let's navigate it. Let's navigate that one. Okay. So that it can feel easier to you, but it's not for somebody else. It's not for the listener. It's so you can have, more spontaneous. I just want kids to feel spontaneous joy in communication and not be worried because the outside world has decided that stuttering is a defect.
And that's the change.
It's the change.
Yeah.
The social relational model will tell you that it's no longer incumbent upon a child who stutters to fit into the fluent society. Okay. It is incumbent upon the society to accept verbal diversity.
Yes.
Wait patiently while someone stutters. Okay. Now, is that going to change overnight? Absolutely not. We've been trying to change it for decades. Probably longer than that. The idea is, though, that once there is the environment becoming more, and it isn't tolerance, because tolerance denotes you got to sort of suffer through it.
Right.
It's acceptance. And then the child can be more self-advocating and say, first of all, sometimes I stutter. You're going to notice that. Now I just went to, older kids. My 4-year-olds don't usually do that.
Right.
But you know what I'm saying? It's more like I'm okay, so you can be okay, but you really need to be okay too, so I can be okay.
Yes.
Right? It's not just the kid needs to be okay, so the listener can be okay. It needs to be reciprocal and really incumbent upon society to make that change.
I love it.
And we better make it in the therapy room or there's nobody to teach, to show society how to do this.
Right. Right.
We have to be a big voice in that chorus. We're allies.
Mm-hmm.
We are allies. We, accentuate the voices. We raise the voices of people who stutter and give them a space to talk for themselves. Because I'm not the expert on stuttering. The kids I work with are the experts on stuttering.
Right.
And
Job, if I'm hearing you right, our job is, I was trying to write this down. Because it was really powerful that we're giving them we're advocating and giving them the space. I'm trying to say that again because I maybe.
Yeah, we are giving them the space to be who they are. It's incumbent upon society to be okay with stuttering.
Okay.
Not for
We're
the
going to
child.
advocate
Yeah.
for this child so that everybody that's dealing with them understands that they're not wrong. Stuttering is not wrong, and that's their problem. And
Right.
they need to realize that we need to not try to fix.
Right.
So we need to teach so we have the environment that they can communicate in any way that they are communicating.
We need appropriate accommodations, but not like, like pathetic empathy where it's like, oh,
Right.
honey, you don't
No.
need to do that one because you stutter, right? Nobody needs that, right? We need to be more understanding and accepting as a society. And then that creates the reciprocal, the child doesn't need to perform fluency
Right.
anymore.
No.
Right. And when they stop trying to perform fluency, they actually have easier communication. It doesn't sound like that's a normal thing, but it's absolutely true. The less they try not to stutter, the easier communication becomes.
I'm sorry, say that again for the people in the back.
Yeah.
One
The
more
less
time.
they try not to stutter, the easier communication becomes. Okay.
That is
Because
what we all need to take away from today, that we are not going to be there to get them to think about not stuttering.
right. Easier communication. That's not code word for fluency.
No.
You can't just go, let's have an easier communication. Let's try that, right? Let's make that one smooth because you already just made it code for fluency.
Right.
So what it is just easier. Did that one feel easier that time? Wow, it looked like you weren't pushing so hard. Was that true? Because I'm not in your mouth. You have to tell me. Were you pushing that hard? No, that one was easier. Okay, cool. Still stuttered. Still stuttered. Yep, because that's the neurology. Now, of course, we're talking older kids on that one, but though there are going to be kids who come out of the best early childhood therapy ever and stutter.
Right.
We just don't have the crystal ball. We don't have the guarantees. We are creating the space to move them back if we can, but we can't give guarantees. We don't take away hope. Right? It's not the age of the child. It's not like if they're still stuttering by 5, they're going to stutter. Never say that. What if they started stuttering at 4.5?
Right.
We talk about the longer a child, this is in our book, the longer a child continues to stutter, the more likely a child continues to stutter. It's the age of the stuttering, not the age of the child.
Gotcha.
Started at 2.5, kids now 5, less likely to move through. Studies will show that. All the Yairi and Ambrose from the U of I, longitudinal studies, and Smith at Purdue, lovely things that we're learning and have learned in the past few decades. So, but we don't go, oh, they're 5. Well, sorry.
No. Yeah. We're going to continue.
Yes. If your child continues to stutter, there will be other things that we will then get involved in.
Got it.
Okay. It won't just be all about you guys, changing this and then the child, having some, fun talking in the therapy room, easy and, bumpy and high and low. Because easy speech is not a problem. It's when you expect easy speech that it becomes the problem. So I can do some easier talking, and that doesn't make me an ableist clinician. Okay. What makes it go off of the stutter affirming is that when we expect it, and especially when we expect it from little kids. Are you serious? Do you want
Right.
to talk like the rabbit or the turtle? What kid is ever going to pick the turtle?
No
I've
one.
never had one in 30 years. I have never had a kid pick the turtle. When I was back then, when I was doing that stuff, and I was as a young clinician, who wants to talk like a turtle? Nope. And it's aberrant, and they're just little, and let them talk.
Just let them talk.
Let them talk.
We need, that's going to be a bumper sticker. That's going to be a t-shirt. Let them talk.
Yep. Because here's the deal. We try to do the least amount possible, like to the child, like, now if the child needs, I want to say this, if the child needs some support in having some easier communication, I'm in, right? I'm just not going to do it so that they sound fluent. I'm going to do it so that they can feel the difference, And yeah, some of that school age stuff, learning about tight and loose and, tight muscles and loose muscles. Yeah. Sometimes it pulls right into the early childhood. Okay. But not everything. That's why we have 2 different books.
Right. Yeah. Right.
Yeah.
So everyone that is listening, I'm going to say your website again. It's stutteringtherapyresources.com. And I know that we're getting to the end of our time today. I would love to keep talking as always with you, but I know that as I had the first time you came on, how much I learned. I fell back for 1 minute when I was like, oh wait, we're going to give them strategies because it's ingrained. And I realized, thank you for stopping me. No, I need that shift.
Yep.
We all need that shift, that we are going to be working on effective communication.
Yep.
And providing the environment to
stutter affirming.
And a stutter affirming environment.
Yeah. And let me just say before we end,
yes.
Now I'm going to switch away from early childhood because one of the things that everybody gets very confused about when we talk about verbal diversity, and we did allude to this in our earlier podcast, it's not that the strategies have no value whatsoever. It's not like you're never going to teach a strategy with school age or adolescents. It's going to be, first of all, it's not all that you're doing because for so many years, that's all we've been doing.
Right.
And we haven't been getting into how the child's experience is going, right? And those strategies have always been mostly introduced to not stutter, to be fluent, to not show it, to show it less. So it's not noticeable. All of those messages are not neurodiversity affirming. None of those messages. So what we want to do is understand if the child wants to have a strategy to ease out of a stutter, right? Then that's an appropriate thing to do. As long as they're not using it to mask. If they're using it to have an easier moment when they get really, really stuck and they're struggling, and then they learn. But here's what happens. You've got to also then be working on acceptance. Because once they won't be pushing and trying to get through that so hard when it's okay that happens. And they'll need that strategy less and less and less and maybe never. Because they're going to let the stutter come. They're going to let the stutter go. Long term. Now, that's not like, hey, no problem. That only took 3 weeks, because the society stigmatizes this so much without even knowing it. We send messages. Well-meaning people send messages of, it's not okay that you just did that. Even though that's not really what they meant, it's kind of like, I'm fixing you. So when society sends that message, kids get it, even at early ages.
All right, listeners, I know we're coming to the end, but I think what Nina is telling us, that we need to be advocates for the change. In our therapy room, in society. And we're not going to be the only voices out there. We're going to help our students and
families. Wow, what would happen with when a caregiver goes, "Oh my gosh, this is which is what happened on that phone call today." She's like, "He said that to me, that I when I'm in therapy, I think about it too much and it makes it harder for me." Oh my gosh. I'm like, "Yes, he's trying to tell you."
Mm-hmm.
And the light bulbs went off in her head, and now she'll be an advocate when other people in the family say, "Stop, slow down." She won't do that anymore.
She'll say, no, let him speak.
Yes, let him talk.
Let him
This
talk.
is the way of talking. Talk. Let him talk, let him communicate. This is the way I talk sometimes.
Mm-hmm.
You're going to notice a stutter. If you're confused, ask me. This is how I want my kids to get eventually.
Mm-hmm.
Like, it's hard, but are you going to continue to change yourself for other people? Because then you're not yourself in that moment. You're not showing up. It's vulnerable, it's risk-taking. That's why counseling is such a big part of what we do in stuttering therapy. And that has to change from all the ASHA to the university programs. We have got to stop. If we're going to switch out of, medical model and strategy, then we better fill somebody's bucket up with
Mm-hmm.
what you do instead.
Right.
Or in addition to. And so there's a lot of people working on this, and, we're still building the plane while we're flying in it.
Mm-hmm.
And, give yourself grace, shift your mindset, and other things will fall into place.
Thank you.
You're welcome.
Yeah. I want to end right there.
There you go.
That you're amazing. I thank you so much for coming back. Those of you that haven't heard the first episode, it's called Embracing Verbal Diversity, Navigating Stuttering Service Delivery in the Schools. I urge you to listen to that one as well. But I want to just say your website one more time. You guys, it's free resources, so much on there, all sorts of resources.
Mm-hmm.
It's stutteringtherapyresources.com.
Mm-hmm.
Nina, thank you.
Yes.
Thank you so much.
Hey, listen, follow us on social media, because I've just been doing, just in this moment, I know this podcast will last a long time, but I've been doing things about how to be a stutter affirming therapist on our Instagram and our Facebook. So follow us on social media, because, not everything gets on the website. Sometimes it's a post, sometimes it's a blog, sometimes it's a practical tip handout, sometimes it goes in a book. We just have stuff everywhere. So hang out with us and keep us all moving forward together.
Absolutely. Okay. Thank you.
Bye-bye.
Oh, I hate to say this, but bye.
All right.
Bye-bye. Thanks for joining us on today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support, and would love for you to write a quick review and subscribe. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Hope to see you on our next episode. Also, please don't hesitate to tell us which topics you would like us to cover in future episodes. To get in touch, drop us a line in the comment section or send us a message on social media.